Good evening, friends. This is Dr. Mainak Banerjee, consultant endocrinologist in Arintegra Hospital, Kolkata. Today, I'll be discussing an interesting, fascinating case of diabetes with the aim of highlighting the role of empagliflozin and nilagiptin combination that has been a powerful addition to existing therapeutic armamentarium for treatment of diabetes. Now, Ms. Kamal is a college professor, 50-year-old female with type 2 diabetes since 4 years. During routine checkup, she complained of generalized weakness. She was hospitalized for acute coronary syndrome 1 year ago and underwent coronary angioplasty. She had a family history. The father had myocardial infarction and who underwent CABG surgery 5 years ago. On general examination, she was found to have a body mass index of 29.7 kilogram per meter square. Blood pressure was 146 by 86. HbA1c was 8.4% on investigation chart, and her lipid profile, LDL cholesterol, was 75 milligram per deciliter, and triglyceride was 156 milligram per deciliter. Now, EGFR was calculated, and the calculated EGFR showed 50 ml per minute per meter square. Urine ACR, albumin creatine ratio, was 290 milligram per gram, and the 2D echo showed mildly dilated left atrium and right atrium. Now, on medication chart, she was already on metformin 1 gram twice daily and glimepiride 4 milligram once daily before morning for diabetes treatment. And regarding the antihypertensive medication, she was on losartan 50 milligram once daily, amlodipine 5 milligram once daily, and clothalidone also. Now, along with that, she also was also on aspirin and atorvastatin. Now, she has a sedentary lifestyle and is trying to avoid the weight gain, and she exercises few times a week. She is frustrated that her weight is unchanged, and now she reports occasional hypoglycemic events as well. So, what are the important challenges in this patient? First of all, she has uncontrolled hyperglycemia as evident by the HbA1c of 8.4. She is obese. She has a BMI of 29.7. She Her hypertension is also not optimally controlled because she has systolic blood pressure 146. She has a history of previous myocardial infarction that puts her in very high ASCVD risk category as per ESC guidelines. And she has also microalbuminuria and CKD stage 3 as evident by urinary ACR of 290 and EGFR of 50. So, what is the risk status of this patient? She belongs to the very high risk category because she is younger, diabetic with multi-organ target damage, and she complains of weight gain due to less physical exercise. So we also need to individualize the A1C target in view of a previous cardiovascular event in this patient. Now, coming to that, type 2 diabetes, we all know, is a complex disease. It's caused by chronic hyperglycemia, which gradually increases over time. It is associated with major severe risk factors like abdominal obesity, arterial hypertension, dyslipidemia, thrombogenic status, low-grade inflammation. These risk factors accelerate anthrothrombosis, resulting in cardiovascular events. Almost two-thirds of patients with type 2 diabetes will die from cerebrovascular disease, and almost half die from coronary artery disease. Now, a better management during the last 2 decades allowed reducing the incidence of cardiovascular complications, yet the residual risk remains high in patients with type 2 diabetes. Now, CKD remains a concern, and heart failure becomes a complication of major interest because premature mortality has come down because of this improvement in treatment in recent years. Hence, ADA recommendation 2019 has correctly recommended a cardiovascular protective agent as fast add-on therapy oral anti-diabetic agents in case of high severities in patients with type 2 diabetes. So in 2015, we know that the era of evolving dimension of cardiovascular care in type 2 diabetes management began with the EMPARIC outcome study, which clearly demonstrated significant benefits of empagliflozin in risk to reduce the risk of heart failure by 35%. Now, among participants with a baseline history of heart failure, empagliflozin was associated with a numerically lower rate of hospitalization due to heart failure and cardiovascular death, with no heterogeneity between participants with and without baseline heart failure. And among participants who had an initial hospitalization due to heart failure, empagliflozin was associated with a near twofold reduction in the risk of subsequent CV death or hospitalization due to heart failure. So it is possible that SGLT2 inhibitors might prevent the development of heart failure in diabetic patients. Positive top-line reports of EMPEROR reduced has been recently published in patients with heart failure with reduced ejection fraction with and without diabetes, and the EMPA-HEART cardio-link study also demonstrated that empagliflozin could produce early reverse cardiac remodeling in type 2 diabetes and stable coronary artery disease. Now, another sub-analysis from EMPA study showed that empagliflozin decreased new onset or worsening of nephropathy by 39% on top of RAS blocker therapy. So the addition of empagliflozin was associated with a slower progression of kidney disease. The CV and renal benefits seem to be maintained independent of EGFR level, even with progressive EGFR decline. So, in addition to these cardiorenal benefits already mentioned, the metabolic outcomes in terms of weight loss and BP reduction is also well known with this SGLT2 inhibitor therapy due to significant osmotic diuresis and natriuretic properties. Now, coming to linagliptin also has a unique profile with a primarily non-renal but hepatobiliary route of elimination, dose adjustment in patients with CKD. And the Carmelina study, which is a linagliptin CV outcome study, confirmed that linagliptin also can reduce the progression of albuminuria by 14%. So thus our patient who is obese, has a systolic blood pressure of 146 and who belongs to CKD stage 3 and microalbuminuria category along with high severity risk category will definitely benefit significantly from a combination of both these agents. So the combination of empagliflozin plus linagliptin definitely offers a suitable component in strategy to achieve the target HbA1c in this patient without hypoglycemia and fear of weight gain. Now, a reduction in incidence of genital infections associated with the SGLT2 inhibitor therapy has also been reported less when a DPP4 inhibitor is added. And it is perhaps due to the better glycemic control, although other possible mechanisms remain to be investigated. And additionally, it would reduce the daily pill burden in this population, potentially improving the treatment adherence of diabetic patients and optimizing the benefits of treatment of diabetes mellitus. Thank you.